Good afternoon, everyone. Welcome to session 142, titled Lewy Body Dementia. My name is Princess Chukwuneke, and I'm the moderator for this session. Thank you for being with us in San Diego, California, as we share in this conference of colleagues seeking to become better advocates for the specialty of gerontological nursing. The speaker for this session is Dr. Sarah Kremen. Dr. Sarah Kremen is a board-certified neurologist with subspecialty training in behavioral neurology and neuropsychiatry. She's an attending physician in the Jonah Goldrich Center for Alzheimer's and Memory Disorders, where she sees patients with memory concerns and diagnoses that vary from typical Alzheimer's disease to early onset Alzheimer's disease, primary progressive aphasia, dementia with Lewy bodies, and other conditions. Please join me in welcoming Dr. Sarah Kremen.
Okay, can everybody hear me? All right, well, this is a big event. It's the first thing we've done in person, at least for me, to speak in front of people for 19 months. So welcome, everybody. I'm going to be speaking to you today on Lewy body dementia. These are my disclosures. And these are our objectives. Basically, we're going to go through what the difference is between normal cognition, mild cognitive impairment, and dementia, and then specifically go through what the features of Lewy body dementia are, how they differ from other types of dementia, and how to know when to implement appropriate diagnostic tests and be familiar with some of the medications that we use to manage cognitive and behavioral features of Lewy body, and to discuss some of the non-pharmacological management as well. So first we want to talk about what is normal. What does normal really mean? So a person is quote-unquote normal if they're operating at their baseline. And when we think about that, there's two different things to think about. One is cognition and one is function. So in terms of cognition, we're thinking about their language skills, their memory skills, visual spatial skills, and frontal executive skills like problem solving or planning or taking initiative. And we're also thinking about their function. Are they able to do their activities of daily living? So can they still use a computer? Can they still drive? Can they do their work? Can they manage their medications? Are they having trouble with bathing or dressing? So if everything is normal in those two big categories, then you could consider somebody has normal, being quote-unquote normal. Then you can have something that's called mild cognitive impairment, or MCI. So this is where somebody has declined from their baseline in cognition, but not in function. So they're having difficulty with memory or their language. Maybe it's giving them a little bit of trouble, but they're still managing all of their basic activities of daily living. So they're still doing their checkbook and not really making mistakes. They're still driving and not really getting lost or having that much trouble. They're basically getting along. And mild cognitive impairment just means you're not normal and you don't have dementia either. It's something in the middle. Then there's dementia. So dementia means that you've had a decline not only in your cognition, but also your function. So now you're not able to manage your medications, you're not able to hold up your work obligations, you're having to stop going to work, you're having difficulty driving, managing the cell phone, et cetera, et cetera. So that's dementia. Dementia is decline in cognition and decline in function. And so we oftentimes talk about dementia as an umbrella term. It's just a description, a definition that just says decline in cognition and function. It doesn't tell you what the dementia is due to. So once you've diagnosed dementia, then you start thinking about what is it due to. Is it due to Alzheimer's? Is it due to some other neurodegenerative condition like frontotemporal lobar degeneration or Parkinson's disease? Is it due to a vascular dementia, like is it from a stroke? Is it because somebody's had traumatic brain injury, or have they had an infection like long-standing HIV that's now progressing? Is it normal pressure hydrocephalus, or is it other things that maybe are reversible? You know, maybe it's depression or it's too many medications, something that actually really isn't truly dementia and something that you could make an impact on. So Lewy body dementia in particular is the second most common cause of dementia after Alzheimer's disease. At least in terms of neurodegenerative disease. So Alzheimer's is always number one. It's the number one neurodegenerative disease. But Lewy body dementia is the second most common. And then in some papers, when you look in the literature, it's second. and sometimes vascular disease is second. So there's a little bit of push and pull because vascular dementia is also very common. So it just depends which body of literature you're reading. It can be very confusing to diagnose dementia with Lewy bodies because sometimes it can look just like Alzheimer's disease. So oftentimes it's missed. So a lot of times people will come into the office, they've been diagnosed with Alzheimer's disease, and it turns out there are other features, and it turns out actually it's Lewy body. Or somebody might look like Alzheimer's disease, but as time goes on, they develop other features, and then you realize, oh, actually this person had Lewy body dementia. So Lewy body dementia accounts for about 10 to 25% of all dementia cases. And if you were diagnosing somebody in the community, it accounts for about 4% of cases. That goes up to 8% of cases in specialty clinics, which is not surprising because obviously there's people there who are experts who are going to maybe be a little bit better at differentiating what they're looking at. But still, we're missing cases because when the cases that come to autopsy do come to autopsy, there's about 10 to 15% of Lewy body. So, and that's only the cases that are coming to autopsy, which is happening less and less frequently these days. So you can imagine that we're actually probably missing quite a lot. So the age of onset, it typically is older, usually over 65 with a mean age of 70 years old, but there is a wide range, so 50 to 85 years old, which is very similar to Alzheimer's disease. The duration of the disease is also, the range is similar to Alzheimer's disease, so 2 to 20 years. I mean, it can be a long span or a very short span, but the duration average is shorter than Alzheimer's. Alzheimer's is usually about 10 years, and this is usually a shorter disease, usually about 5 to 7 years. It affects men slightly more than women, and there are some increased risk factors. There's increased age, which is obviously the same for any neurodegenerative disease, having a family member with dementia with Lewy bodies, and there is an association with ApoE4. ApoE4 is a risk gene, very common in Alzheimer's disease that when we're doing trials and when we're talking to people who have Alzheimer's disease, we sometimes look and see if they have ApoE4 only because it increases the risk, not because if they have ApoE4, it doesn't mean they'll actually get Alzheimer's disease. Same here. It doesn't mean they're going to get dementia with Lewy bodies, but it does increase their risk. So the presentation, basically, that people have a gradual change in cognition and thinking in a persecutive pattern, and that's a made-up word, but basically it's to describe that people have perceptual difficulties, so they oftentimes have difficulties finding their way around, picking things up, putting a leash on the dog, so that's visual, spatial, or perceptual, but they're also having difficulty with frontal executive problems, so planning, problem solving, initiating things, deciding to change their mind, staying focused. So that's where the persecutive comes from. So it's frontal and visual spatial. And so how is this different from Alzheimer's? That's a really key thing to think about. So I'm going to step into the Alzheimer's world for a minute. And when you think of Alzheimer's, we think of memory problems. And we think of short-term memory problems. People can't remember the conversation they had yesterday. They repeat themselves a lot. They ask a lot of repetitive questions. And the reason that that's happening is because their hippocampus isn't working. And if you think of the hippocampus as being a tape recorder, which I know nobody uses anymore, the tape recorder doesn't record very well. And since it doesn't record very well, then the information never really gets in. So when you give them a memory test, I mean, they don't do well because they never really got the information in the first place. So that's an encoding problem. The problem that the people with dementia with Lewy bodies have, at least initially, is different. It's a different type of memory problem. Their hippocampus works. So they're able to take in and record the information. It's not a problem of fidelity. It's either a problem of not paying attention very well, or the information gets in, but they can't find it. So it's like, I'm going to go back again, old-fashioned, but they can't find it in the Rolodex. It made it to the Rolodex from the tape recorder, but they can't find it. So it's a lot of searching, and it's really hard. So it's a recall problem, but it's not an encoding problem. So when we test people, they have retrieval problems, but if you give them a cue, they'll probably get it. Whereas in Alzheimer's, no cue is going to help them because it never made it in. So that's the kind of memory problem. That's the difference. The other thing that's very striking with DLB is that really they do have frontal features that are much more prominent much earlier. So again, this difficulty with staying on task. They're oftentimes just drifting off. They're getting lost in the middle of doing a task, not being able to really figure out how to go through things or multitask, or how to problem solve doing things that they used to be able to do. And also the visual spatial aspect of really having trouble, finding their way, or again, reaching for things in front of them, or, tripping over the dog happens a lot more, things like that.